and welcome to PCR London Valves 2023. My name is Patrick Calvert from Cambridge in the United Kingdom. It's my very great pleasure to welcome today Grzegorz Smolka and also Xavier Freixa. Welcome today.
Thank you.
Today we have the pleasure to talk to you about a topic that's very close to my heart and to yours, I know, paravalvular leaks. Greg, well, I'd like to start with you first of all. Could you put this in context for us, please? How frequently do we see paravalvular leaks in the general practice?
Yeah, thank you for this excellent question. There is, there's some bias produced by the fact that you are working with in the centers specialized in paravalvular closures, that there's an impression there is a lot of paravalvular leaks, but in reality, I think that it's about 100-150 procedures needed in Poland yearly. Poland is a 36 million population. So I don't know in persons, but I could calculate the demand for a population.
So I think, Greg, there's some data to suggest that the percentage per valve is in single-digit percentage, but actually important paravalvular leaks that need closure is much lower.
Exactly.
So, Xavier, can you give me an idea of what kind of patients are suitable for paravalvular leak closure?
Well, exactly. At the end, you need to think if just the symptom, it's related, just to the leak. And actually, you have like a 10% of leaks after surgery, so maybe like a small percentage, as Greg said, like are related. Basically, the symptoms are two, I would say, like heart failure and then hemolytic anemia, or just both. So then, if you think that you have like those symptoms and you have like a significant leak, I think that you can think that it's just worth trying to treat the patient just to improve those symptoms.
So you were suggesting that paravalvular leak closure via transcatheter approach should be first line for most patients? I mean, which patients would you not consider it first line?
Well, I think that basically transcatheter closure, it's a very safe approach. So I think that can be tried first. And if it doesn't work, you always have the surgery. Basically, I would say that probably the worst ones are just the very large ones with rocking movements of the valve. But for most of the patients, I think that a first approach of transcatheter technique, it's good.
And maybe endocarditis, active endocarditis would be an exclusion for.
Well, of course, if you have like an acute, process, you always have just to have like a stable situation. Of course, like an infective active disease, it's like a contraindication.
Greg, can you tell me some indication of the workup that you need to do to be a center that can undertake these procedures?
Yes, the planning is based on echocardiography and mostly on. After we confirm the indications, we have to assess the geometry, the possibility to put something inside. And on the first place is transesophageal echocardiography. So in the staff dealing with paravalvular leaks, we have to have very experienced echocardiographer, not only to qualify, but also to lead the procedure. In case of need of additional information, the CT scans are very useful. And actually, I think that having both of these images, we may plan almost all procedures.
Yes, I agree. Transesophageal echo is enormously important for these to determine the size, the minor axis, the major axis, and the position of it. I personally use CT principally in post-TAVI leaks. I find it can be quite complicated anatomy, and they seem...
You're right, it's a different story, yeah. Post-TAVI leaks are.
Xavier, can you tell me a little bit about what kind of outcomes we might expect from transcatheter closure, maybe comparisons with surgical treatments?
Well, basically, when we started the program, we were concerned that the surgeon will get upset, to send the patient. But actually, they're the happiest, guys in the hospital, because the problem with the surgery that they have like a high recurrence rate, because those patients had bad anatomies, and the mortality of those patients, it's also very high because redo after redo, increases the mortality. So actually, I think that in general, surgeons are very happy that we try to treat those patients, because if anything describes, the technique, it's safety.
Yeah.
So it's super safe. It's difficult if you're just like doing regular things. It's very difficult to have a complication. So then, if a part of that, you are effective, I think that it's a win-win.
Yes.
So basically, I think that always, like any other intervention, it has to be a heart team, and like just discuss the patient with the surgeon, and then maybe like come to an agreement. First transcatheter, and if it doesn't work, then go to surgery.
This is a cornerstone of heart team discussions. Patients who get paravalvular leak closures, it's not generally because of bad surgery, it's the terrain or the substance to which they're sewing into. And it's that understanding with the heart team. And in our own institution, I have surgeons can come to me and say, I've taken this valve down 3 times in surgery, can you come and close it now? And of course the answer is, no, it doesn't need to be done now, but we'll be able to do it in the future. So I think it's a great treatment. It doesn't preclude surgery in the future, and I think the hallmark is very safe. So just to summarize, transcatheter closure of paravalvular leaks is an extremely safe procedure. It is fairly unusual, and it definitely benefits, like all procedures, for volume. Therefore, you need a heart valve, comprehensive heart valve center and team with an interest in the procedure, with the correct experience and equipment ready. But it's a very safe treatment, and one that can be offered as a first-line treatment for almost all paravalvular leaks. Thank you for your time.
Thank you.
Thank you.